My name is Kelly Askew. I am the director of the African Studies Center, and it's a pleasure to welcome you here today to an II Roundtable. II Roundtables are intended to promote informed discussion on contemporary issues and events that affect our world. Today's roundtable is co-sponsored by the African Studies Center, the STEM Africa Initiative, and the Department of Microbiology and Immunology at the U of M Medical School. We have a series of very distinguished panelists, and we have in addition several expert discussants who will be participating in the Q&A in terms of answering questions in addition to our panelists. I will run very quickly through some bios to give you the backgrounds of those involved. But I just want to say that our goal today is twofold, primarily. One is to disseminate accurate information to counter all the misinformation that is circulating with abandon about Ebola, and with the hope of thereby, through this accurate information, tempering some of the widespread fear and concern that seems to have overtaken not only our country, but many others. Number two, we want to speak about beyond Ebola, which has been queried by a number of people, because global viral epidemics are not going to be less in frequency typically. I mean, these are problems that have emerged before. If you remember Asian bird flu, H1N1, this is one instance, and we need to talk about the bigger structural issues that give rise to them. So that's going to be part of the discussion as well. So let me turn over and start introducing our speakers today. To my left is Oveta Fuller, who is also the Associate Director of the African Studies Center. She's an Associate Professor in Microbiology and Immunology at the U of M Medical School, and she studies early events in virus-host interactions and infectious disease control. Her laboratory research and publications examined the herpes simplex virus, its entry and membrane fusion. Current research is focusing on how to eliminate HIV/AIDS through community mobilization using rigorous biomedical science-based training through the vehicle of religious leaders networks in both Zambia and the United States. To her left is my colleague Mike McGovern, who is a political anthropologist here in anthropology at the University of Michigan and has long and extensive experience working in West Africa in the countries we'll be speaking about, especially Guinea today. He uses a variety of sources from kinship idioms to aesthetics of state-sponsored folklore to try and understand post-colonial states within the arc of longer historical trajectories. His book, Making War in Côte d'Ivoire, focuses on the sociology, political economy, and dramaturgy of the Ivorian civil conflict, and a second book called Unmasking the State looked at state formation and ethnogenesis in Guinea over the course of the 20th century. I should also mention that he once served as the West Africa project director of the International Crisis Group, a Brussels-based think tank that analyzes causes of armed conflict. To Mike's left is Renee Gerring, who is the laboratory supervisor for the Division of Engineering at the University of Liberia. She is a chemist by training with over 20 years' experience engaging in scientific projects both in Liberia and in the United States. She was trained in chemistry from York College in New York and has worked as a consultant for the United Nations Industrial Development Organization. She is here with us as a University of Michigan African Presidential Scholar. And to her left is Joe Eisenberg from the School of Public Health, where he's an associate professor of epidemiology. He studies infectious disease epidemiology with a focus on waterborne and vector-borne diseases. He does theoretical work in developing disease transmission models, and he also does empirical work in designing and conducting epidemiological studies. He has most recently been working in Ecuador. And he's also working on projects for the WHO and, if I remember correctly, NIH. In addition to our four panelists, we have four expert consultants who will be weighing in the second half of the conversation today. We have Gessler Murray. You want to just raise your hand, Gessler? Gessler is the chair of the Department of Geology and Mining Engineering, also at University of Liberia. He once served as Assistant Minister for Mineral Exploration and Environmental Research, in addition to various other posts at the Ministry of Lands, Mines, and Energy in Liberia. He too is here today as a University of Michigan African Presidential Scholar. Also with us is Sandro Cinti, who is in the Department of Internal Medicine at University of Michigan Medical School and a professor of infectious diseases. He also serves at the Ann Arbor Veterans Medical Center. He's an expert in biodisasters and bioterrorism and has been part of the biopreparedness efforts at the local, state, and national level. Currently sits on various hospital committees here at UM, including Disaster Committee, the Pandemic Influenza Committee, and most recently, the Ebola Committee. Also with us is Adam Loring, who is also on the faculty at here at the University of Michigan Medical School, where he does a lot of research on basic and translational research in virology. He's a physician scientist. He's also in the clinics, caring for hospital patients with infectious diseases. He studies how viruses evolve and how to use this knowledge to design better vaccines and antiviral drugs. Welcome, Adam. And last, certainly not least, is my colleague, Frank Anderson, from both the University of Michigan Medical School, Department of Obstetrics and Gynecology, and an appointment also in School of Public Health. He is director of the global initiatives for the Department of Obstetrics and Gynecology and has extensive experience working in our partnerships with Ghana, which go back to 1986. His research focuses on both hospital and community-based interventions to improve maternal and neonatal health and decrease mortality. So these are our panelists. I welcome you all today. I welcome those of you watching us by video streaming and on Twitter, and let the games begin. I turn over first to Oveta Fuller, who will be giving some background on the disease and the virology of it.
Thank you, Kelly. I just want to remind people to turn your phones off, please, if you have them. We are live streaming, so if you would do that for a minute. Thank you for coming, and I'm glad that the International Institute has hosted this panel. My task is to lay a foundation for a discussion that will, one, provide much needed accurate information to counter the misconceptions, increase understanding, and allow actions to reduce fear and actions for wellness. And secondly, it's to open up the forum so we can move to topics that typically you don't hear about when you hear these days about Ebola in the media or even in some forums. So what we hope to do is to actually take a look at what is happening in Liberia, Sierra Leone, and Guinea, and how people here may help and why. What factors contribute to this perfect storm that we're in, and how we might prepare so it does not occur again in other global health crises. And lastly, what is likely to be the outcome of this epidemic, and what key lessons can we learn from this 2014 epidemic? So that's what I would try to do. So why Ebola? Let me just tell you, I'm a virologist, as she said, who has studied herpes viruses and influenza for many years. So I'm really fascinated by viruses. And I also teach courses to medical dental graduate students. We always use as a critical thinking piece for many years now, what would happen if Ebola, a very lethal, a very deadly virus, were to not be in the isolated areas where containment is what is used to take care of it. And that was a critical theoretical question on exams. And so now here we are. And then the second reason is that I've switched now to out of lab-based research into research in communities where we're working with HIV in people. So in Zambia, there are many regions very similar to what is the regions in West Africa. All right, so I wondered back in April, why are we not dealing with this more rigorously? It is indeed a perfect storm. This Ebola epidemic is different, like we've never seen any before, perhaps not since the 1918 flu pandemic. So here are my questions. What is Ebola? First of all, you should know it is a virus. It is a microbe similar to influenza or HIV, not a bacteria, but it's different from influenza and HIV. It's in the family of filoviruses. There are 5 different kinds. Thank you. There are 5 different kinds of viruses that are, quote, called Ebola viruses. And they can range from up to 90% lethal to a lot less. This is about 55% fatal. This virus has a complex structure. It's not a nice round virus like the common cold virus or the influenza virus. It's more like a fiber, and that probably contributes to the fact that it is so infectious. And let me distinguish between infectious and contagious. There's a difference. Infectious is about how many particles it takes to enter a person to cause disease. So probably 1 out of every 2 Ebola viruses are able of getting in and initiating an infection. We can compare that to, for instance, the common cold, where about 1 out of every 100 or 200 particles are likely to get in and cause disease. So you have a lot of particles, but you only have 1 in that group that can be infectious. Or take herpes viruses, one that I studied a lot. 1 out of 20 particles might be able to be infectious. So Ebola is highly infectious in the ability of a virion, one virus, to cause disease. However, it is medium contagious. What do I mean? I mean it's not airborne. It takes direct contact with fluids in order to get the virus to a person. So it's not like influenza, which is highly contagious, or the common cold, which is highly contagious because they are airborne. So Ebola is highly infectious and only medium contagious. All right. What has caused this epidemic, which is different than any we had before? A lot of my colleagues, Frank is going to talk about that, Renee and Mike are going to discuss what has led to this perfect storm. A medium contagious virus is transmitted to people in contact during their daily life activities, and we'll talk more about some of these. We'll talk more about the lack of infrastructure, the ability to handle any one patient or person or a group of people who are infected, which has contributed to this West African epidemic. So these conditions to allow transmission increase when we actually are in developing countries or countries where the infrastructure is different than here in the U.S. The second point I want to give you is what are the symptoms of Ebola virus? Ebola virus is the name of the virus. It was first discovered in the Democratic Republic of the Congo in 1976. It's named after a river that's there. The disease is called Ebola virus disease. And it is an infection that takes about 2 to 21 days from the time the virus enters the body until there are symptoms that show that the person is infected. Usually the symptoms show up for most people somewhere between 8 and 10 days after exposure. What are those symptoms? High fever that doesn't go away, headache that doesn't go away, muscle aches, stomach pain, fatigue, weakness, sore throat, diarrhea, vomiting, hiccups, red itchy eyes, maybe rash, ultimately leading to bloody diarrhea, vomiting, and external and internal bleeding. So it's not it's a very severe disease. And the only way we can handle it, or what we do, is to provide supportive care to help reduce the fever, to make sure the person remains hydrated, to make sure they get some nourishment. So this is supportive care. There are no real drugs or vaccines at this moment. About 45% of the people in the West African epidemic recover from Ebola infection, which means about 55% do not. I talked about the supportive care. So there's no way to fix this except to support the person through the infection so their natural immune system can kick in and put down the virus infection. Let's talk a bit about what causes the symptoms we see. With influenza, which most of you are familiar with, the virus gets into the lungs and it is tropic, or it has a natural ability to replicate in tissues of the lungs. For hepatitis viruses, they have a natural ability to replicate in the liver. Ebola has a very broad tropism, ability to replicate in many different kinds of cells. So when it enters the body and goes through the blood, it's able to attack lots of different kinds of cells, which ultimately ends up in the symptoms that we talked about: organ failure, shock, and possibly death. The immune system for people who are supported ultimately does kick in and does put down the virus, and then that person is immune to that particular strain of Ebola. There are no proven therapeutic agents. The ZMapp that we heard about earlier was composed of an artificial antibody and human serum. There are no vaccines at the moment, although there are vaccine trials in process. Okay, the third point I want to make is Ebola transmission occurs from the natural reservoir, which is probably fruit bats, is what CDC is thinking at the moment. And these are found in caves in rural areas. So how does it get from there to people? So when people hunt animals, and animals also may interact with bats, those animals may get infected. And they may transfer to a human, or a human may touch the bats. You may find a dead bat. That's where you're told not to touch dead animals here, even in America. This epidemic started in December 2013 in Guinea with patient 0, who was a 2-year-old, who was attended by his mother and grandmother, who subsequently died of Ebola. They did not know what it was. They probably had no clue, because Ebola had never appeared before in the 26 epidemics. It had never been in West Africa before. It always had been in the DRC or in Central Africa, in much more rural areas. It reappeared in March 2014 when the World Health Organization declared it as Ebola virus and identified it as the Zaire strain. This lack of knowledge, this appearing in countries where the borders are close together and families cross the borders all the time, partially led to the perfect storm that we are in for the pandemic that we see now. The last thing I want to talk about is prevention and control. There are no drugs and no preventions. The only thing we can do is isolate and contain. So therefore, we need to isolate people who are infected, and not allow them to have contact with even caregivers. The isolation period is typically 21 days. Healthcare workers are very susceptible. Children are also infected. It infects everybody. To this date, we have about 9,000 known and suspected Ebola cases, some 4,500 deaths, and I think Joe will talk a little bit more about that. Others on the panel will talk about what happens with people who die with burials with the corpses, which are highly infectious. Others will talk about conditions for why we can't seem to take care of patients or people who get infected in the developing countries. And others on this panel and our discussants will talk about infectious diseases around the world and what we're doing to prepare. So in closing, I want to say Ebola is an RNA virus. It is able to remain in a host in the natural bat, but when it gets into humans, it can cause disease. We all should know what it is. We should all know not to continue the misconceptions. It is not airborne. We all should be able to practice good hygiene, not only for Ebola, but for other infectious agents that are out there. The key to ending this crisis is to rigorously do what we know to do about Ebola: isolate, contain, and trace contacts. The last statement: no man or woman or country is an island into itself. We are joined in this interconnected world. So all over the world, we need to work very hard to stop this in West Africa. Thank you. So I pass the torch to my colleague.
Thank you. Now we turn to Mike McGovern, who will be speaking to us about the cultural context. You have a map up of West Africa now, the setting of the current epidemic, what did and did not contribute, etc. Thanks, Mike.
Thank you. Oveta and Kelly, thanks for organizing this and for your comments already. I'm an anthropologist, so I guess I'm supposed to talk about customs and culture and stuff, but I'm a political anthropologist, so I'm actually going to start out by talking about politics and economics and then move toward culture, because the two things are really quite inseparable. Some of you may have heard stories about teams of humanitarians and also representatives of the governments in Liberia, Sierra Leone, and Guinea going into villages where there is Ebola or there was a risk of Ebola, and those people being forced out of the villages, even bridges being destroyed so that people can't get access, throwing stones, and even worse. And so this may seem totally irrational. It may seem like people are doing exactly what they should not do in their own self-interest. I want to try and sort of explain why a situation like that might happen. I've been living on and off since 1989 in the region of Guinea that borders Sierra Leone and Liberia. I've also done some research in both of the other two countries. I'll talk mainly about Guinea. People in that forest region of Guinea, which is right around there, near the Liberian border, have been very marginalized from the rest of the country over the last 55 years of independence. And as you may know, there have been civil wars, right, in Sierra Leone, in Liberia, going back to Christmas Eve of 1989. Those wars decimated those two countries, but they also contributed to the degradation of the public health, the educational, and the road infrastructures, among other things, in Guinea, too. Guinea, if you go from Liberia or Sierra Leone into Guinea, you might very well think that there had been a civil war there, too. The situation is not much better in all of these regards. And so when you hear about people wanting to avoid hospitals in the context of this Ebola epidemic, or people wanting, to basically keep the public health officials away from their villages, it has to do partly with the fact that, right now, if you have a fever and you report yourself to a hospital, you will be put in an area that is either filled with people who do have or are suspected of having Ebola. This is a malaria endemic region of the world, okay? Lots of people have fevers a lot of the time, and it's not all Ebola. So what happens? You've got malaria, you've got 102-degree fever, they put you next to a bunch of other people who have Ebola. Well, now you've got Ebola. You didn't before, now you do. Okay, that's just one of many specific kinds of problems that I could enumerate. And it comes from basically a lack of investment in the health infrastructure. And I want to be very clear that that lack of investment has as much to do with all of us in this room as it has to do with the governments of Liberia, Sierra Leone, and Guinea. What do I mean by that? All of you who pay taxes to the U.S. government, more than $500 million went into the reformation of the Liberian army after the peace agreement in October 2003. A tiny fraction of that amount went into reconstructing the health infrastructure of Liberia. Okay, so just as in this country, we put a lot of money into security and even surveillance of our own citizens, and a lot less into education and health and fixing our roads, as anybody who drives around Ann Arbor can attest. Our priorities when we act as donors in West Africa are, again, to privilege security and stability, and to put a lot of money into reforming the armies, in fact, of all three of these countries, and much, much, much less into education, health, and roads. So that's just a little bit of broad political and economic context for explaining why people actually, almost every Guinean I know, would talk about hospitals as a place one goes to die. Not to be cured, not to be healed, okay? A hospital is a place you go as the absolute last resort. When traditional healers and other things have failed to work, it's where you go to die. So that's a pretty heavy sort of thing to say, but I think it's a necessary context for us to understand why people might have a lot of skepticism about what we consider to be, good practice in medicine. Secondly, there are a whole range of customary practices which have contributed to the spread of the disease. Just as here, we have undertakers that prepare bodies for burial. There are specific people who are usually in a kinship relation to the deceased who do that kind of a work. But I just want to invite everybody to imagine if your parent, for instance, was diagnosed with tuberculosis at the hospital, and the next thing you know, they said, well, they have to be quarantined, and then the next thing you know, a week or 2 weeks later, you're told that they're deceased, and then the next thing you know, you're told that they had to be buried in a safe way so that you actually never had any chance to say goodbye to them or have any kind of a closure with them. That's the kind of thing that's being proposed to people. And as a colleague of mine, I think, put it very nicely, it's one thing to die of Ebola, it's another thing entirely to be robbed of the possibility of any kind of a decent afterlife, right? And so the kinds of preparations, which, people call them traditional burial practices, customary burial practices. I don't know what burial practices that are not traditional or customary are, right? They vary a little bit from place to place, but it's basically what people do to actually prepare people for a proper passage into the afterlife. And when people are being told that that's impossible, they're not going to have the opportunity to do that, that's a very painful and threatening thing in the context of all the fear that's already there. So I want to just finish by saying these are both pretty heavy things, and what's happening in the context of the inability to deal with the disease within the regular health system is that people are increasingly even being encouraged by international public health people to deal with it locally. And I just want to finish by saying there's actually a tremendous amount of local knowledge of how to deal with infectious disease in ways that go back several hundred years. I'll just give one example. Smallpox, which was still existent in this part of West Africa in 1968-69. Those were the last smallpox outbreaks. So elderly people in these villages actually remember the ways that people inoculated. There were practices of variolation that had nothing to do with modern smallpox inoculation, isolated the sick, and in fact people would build special houses where the sick would be kept. If they became well, then they would leave. If they died, then they would be buried, and then those houses afterwards would be burned. So there is a lot of local knowledge that people can leverage in conjunction with international public health knowledge in order to sort of improvise ways of dealing with this outbreak, which might be, okay, it's quacking, and so I'm going to stop. Thank you.
Thank you, Mike. Our next speaker is Renee Gerring, who left her country of Liberia at the end of August to join us here in our University of Michigan African Presidential Scholars Program. She'll be here for 6 months, and therefore she can offer our panel and our audience today the perspective from within, how Ebola is affecting daily life in Liberia, the current needs, etc. Welcome, Renee.
Thank you, Kelly. I'm going to first try to explain how the virus spread in Liberia. I'm going to give personal experiences. At first, the first case was diagnosed in the northern part of Liberia, where we border with Guinea. The government went ahead, did a massive awareness, and it seems like things were kind of under control. In May of this year, the second outbreak came from a passenger who came from Sierra Leone, and she went into the capital city, Monrovia. She visited 3 hospitals. The first one, she was treated for malaria because there's similar symptoms, and was sent home. The second time, same scenario. The third time, her condition was worse. She was exhibiting some Ebola symptoms, or more Ebola symptoms, where she was vomiting, having diarrhea, passing blood, and then she was diagnosed with Ebola. Now just imagine, the first hospital, she had been treated by doctors, nurses, who went home and exposed their family. Second hospital, same thing. The third hospital, people interacted. In Monrovia, nobody knew or had Ebola centers. So people started to panic. Within weeks, Ebola was all over the place. People were falling with the virus. Our health system was down. I mean, is down. We really weren't equipped to handle one, let alone 1,000 cases that were coming up. But in any way, I'm supposed to talk about the effect it had on our lives, apart from death. Ebola does consume your body, your life. It does take control over. It does take control over your movement. From the awareness, they tell you that you shouldn't interact, shake hands, move around. You're constantly in fear. People become a threat. Simple saliva is a threat. You don't want to stand before somebody and have the saliva touch you. Handshake, a social way of greeting, became a threat. We couldn't shake hands. We couldn't hug. We couldn't move around. Community became paranoid. You couldn't interact with people. Your life became confined and kind of isolated. Depression would kick in, constantly thinking and afraid of who would be the next person. You got doctors and nurses and citizens falling, dying of the Ebola virus. And you couldn't trust anybody. It just was an unbearable, abnormal lifestyle. Your life as you know it does not exist because you had to take extreme measures to prevent yourself from being infected. Now, as the condition worsened, the government was drastic also. They closed schools, hospitals were closed down, health workers ran because they were not equipped. People fell sick, couldn't go to the hospital because they were afraid of being infected. There was a story that patients from the hospitals actually walked out of the hospitals, those who could walk, because they learned that nurses and doctors were sick with the virus. And they were afraid, already sick with something else, they were afraid of getting infected with the Ebola virus. Businesses were shut down. People, it just became unbearable. I mean, life was not the life you knew, and we had to cope by just existing, avoiding and moving around, existing, move when necessary, trying to keep your head above water. Okay, that's basically the lifestyle that we had to conform to avoid being infected. Now, as a Liberian, my concern would be how can we stop this virus from spreading? How can we help with mobilization? How can the government, I'm wondering how can the government build up the healthcare system, and how can our health worker be empowered so we can actually try to combat this virus. Thank you.
Thank you. Thank you, Renee. Our next panelist is Joe Eisenberg, who will be speaking about the predictions for duration and impact of this epidemic, factors to consider, is it controllable, less controllable, etc. So to you, Joe.
Thank you. So I'm going to be presenting from the perspective of public health. And in my area of research, which is epidemiology and mathematical modeling, we rely a lot on data to understand patterns of disease over time and space and understand what's causing those patterns of disease over time and space. And so we are very interested in understanding what it takes and how to predict the extent of an outbreak and the duration of this outbreak. Unfortunately, with Ebola at this point, our predictive abilities are quite poor with respect to understanding the extent of the outbreak. And largely that's because oh, sorry. Is that better? Yeah. So largely, our inability to be able to predict what's happening is because the cases in West Africa right now are really increasing, what we call exponentially, that they're increasing. Oh, it's on. Oh, this must be better. Okay. So, sorry. The cases are increasing over time exponentially, and therefore there's no evidence that there is any kind of controlled or containment of this of the disease at this point. And so all we can do when we're predicting is to say, well, and this is what people have done in a lot of different universities. That's what our group has been doing. That's what the CDC has been doing, is trying to predict what the number of cases will be in the next month if there's no containment, if there's no controllability. So we've seen numbers of 20,000 cases that we expect to see next month under those conditions. And we even see some dire predictions in the press of 100,000 cases over 9 months. Again, if there's no containment, if there's no ability to control this outbreak. And I think that these dire predictions of 100,000 are really ill-informed, because we see a lot of evidence that there is finally, probably slower and later than we'd like, but finally some mobilization from the international communities to bring resources into these communities. And really this is a virus that has, and we've heard before, exploited a situation of extreme poverty, exploited a situation where there's very little health infrastructure to actually address a disease like this. And there are a number of ways in which this outbreak, we can see an outbreak like this slow down. One is just through immunity. We actually have a lot of evidence that there's been quite a few people that are exposed to Ebola in Liberia, in West Africa, that don't get sick. And we see antibodies build up in these individuals, and therefore they're protected from future exposure. And that's one way in which we see potentially a slowdown of an epidemic, and we obviously don't want to rely on that. Another way is through control and containment. And the most concrete way to do that in a situation like this, where, again, this virus has been exploiting a very poor infrastructure area, is to provide more capacity to these hospitals. We want to lower the risk associated with healthcare workers and doctors in these hospitals. We want to build capacity with respect to being able to house the sick people that come to these hospitals. So we want to improve the infrastructure within hospitals. We want to build more hospitals. That's one way in which we will be able to contain this outbreak. Another is we want to deal with those people that are sick at home. We want to provide resources, education to people that are sick at home, that for a number of reasons, not everyone is going to make it to a hospital. And we need to be able to contain transmission within households as well as within these households, as well as in the hospitals. Because largely the way in which this disease is transmitted is through direct contact of bodily fluids of people that are very sick or people that are dead. It's not a very transmissible disease, as we heard before, and that's actually the good news with respect to containment, that just a little bit of containment, we should be able to see a slowing down of this increase of number of cases that we have been seeing week after week after week. That a small amount of control should show some evidence of containment. I also want to talk a little bit about the risk associated here in the U.S., that people that have a lot of concern with the risks associated here. The risks associated with any kind of spread of Ebola in the U.S. is very, very, very low. Again, this is a pathogen that has exploited an area with very low resources, impoverished and low health infrastructure. That, in contrast with the U.S., is a completely different situation. That being said, we will be seeing cases coming into the U.S. The incubation period of a disease like this, that is the time it takes from being exposed to actually showing symptoms, is on average 10 days and can be as long as 20 days. So we can expect people that have been exposed may come to the U.S., and that's already occurred. But there's very, very incredibly low risk that any case like this or any disease like this will actually spread in a country like the U.S. And I'd like to just close with the idea that, future outbreaks of Ebola will occur, and they will occur in different parts and different communities within Africa, and it will continue to exploit areas that have poor health infrastructure. And I think the question and the thing that we need to think about and learn more about is how we can mitigate these kinds of emergent activities with respect to improving the resources in these different communities to address this public health concern.
Thank you, Jim. So we did want to allow a lot of time to interact with the audience. I have a series of questions to get us started, but if you have questions, there are note cards that you just raise your hand and someone will bring you a note card. You're welcome to write down a question. We also have Twitter questions coming in. So let me start by throwing out a question to some of our expert panelists. We've heard about the differences in the healthcare infrastructures, which vary widely, and it's no surprise that the two post-conflict countries, Liberia and Sierra Leone, are the ones with the highest number of cases in this region. How and what can be done now so that this cannot occur given these differences in healthcare infrastructures? Perhaps Frank and Gessler, you can start us off, Gessler. That's okay. Oh, okay. Well, pass it to Frank first, and then we'll get started.
Thanks, Kelly, and thank the panel for that really broad perspective. And I would just like to follow up a little about what Michael talked about and about health infrastructure and focus on health systems. I think over the years of development, post-colonial healthcare development, a lot of focus has been on vertical programs that could be implemented outside of a health system, say the eradication of smallpox, getting everyone vaccinated. And Margaret Chan at the World Health Organization has talked about the lack of health systems development. And part of what we're doing now is sending hospitals and CDC people, to countries to create the health system. This is not the first health system problem. I work with maternal mortality. That's why I'm here. Maternal mortality also is not a vaccine preventable disease. It requires a health system. It requires a deep investment in healthcare workforce and the systems in place all the way from the communities to the central areas and working with donors and working with governments, and having just been to a meeting of a big donor, people are interested in their agendas of accomplishing certain conditions at the expense, I think, of the health system.
Thank you. Gessler.
I should say something? Okay.
I was going to ask you, from your perspective as both a Liberian and an educator, what do you anticipate will be likely outcomes for Liberia, and what historical or recent events can help enlighten us as to the current situation?
Well, let me just indicate that the domino effect is so obvious amongst these three countries. That if I can make an analogy, that when one country sneezes, another country catches the cold. The Ebola outbreak has had the same impact as the Civil War, except that the Ebola is by nature, and the Civil War was man-made. I would like to allude to a comment made by Michael in respect to the political situation that none of these countries, referred to as the Mana River Union countries, can pursue individual development agendas without collaboration and cooperation with other countries, because the quality of life in all of these countries is so very, very poor. If I can just give you some brief statistics, as it relates to Liberia, I think which the poor quality of life also helped to accelerate the spread of the disease in a country where 80% of the population lives below the poverty line, less than $1 per day. I think according to the HDI ranking, Human Development Index ranking, Liberia is about what the second or third poorest country. So the situation was also exacerbated by overpopulation. Monrovia in 1990 had a population of 700,000. Today, Monrovia has a population of 3.5 million people. So you have an overcongested city, and you also have overcongested households. It is a luxury to find a family of 10 with each kid having his own bed. They all have to share the same bed, perhaps with some of the parents. So all of those conditions help to spread the virus. Stop you.
Thank you. Sandro,
Yes.
can you speak about the preparedness both of the United States in general, U of M in particular?
Yes, I can.
Thank you.
We're I think the question is about epidemic, and it's not an epidemic proportions here, and really the risk to the public is almost nil. But what we're really working on at the hospital level is getting ready for somebody that might come in, just like they did in Dallas. And so we're all very aware of that. There have been, and so our hospitals all around the country are preparing for the possibility of a patient either coming from one of those areas. And right now, we're just looking at Guinea, Liberia, and Sierra Leone. And just like Gessler was saying, a sneeze in any parts of these parts of the world can cause disease in other parts of the world. And right now, when you're isolating those three countries, that seems manageable because, as the CDC is telling us, so there are only about 150 people at any point coming into this country from those three countries. But if this spreads outside, for example, Nigeria was on the list. Nigeria has done a great job of eradicating this, and they've been free now for 42 days. So they're no longer a country that we consider a high-risk country. I think it's important to point that out when we say how this can be contained. And these patients came into Lagos, I think that's how you say it, a country of 20 million people, Lagos, a country of 20 million people. So this can be contained, and as Joe was saying, this is a containable virus. Oveta did a great job detailing how this goes. Oveta and I work together all the time, and I can never add very much to what she says, so I won't even try here. We realize that right now, if this spreads outside, then the problem in the centers are a lot more, because imagine somebody coming into the hospital, and the questions are going to be, have you been overseas recently? Have you been to any of these 3 countries? What if it ends up being, have you been to any of these 4 countries, 10 countries, 20 countries? That makes it a lot more difficult. We shouldn't be worrying about somebody coming from Africa, right? Almost all the continents can fit into Africa. So we don't worry about that. But this shows you there are a lot of questions, and there are a lot of questions about why don't we just stop allowing people to come in from those countries, and why don't we not send people to those countries? Close off the borders, leave them alone. There's a lot of that out there. The reason is because of the spread of this disease. We need to help. You've heard what's happened here. I think these kind of discussions, if we saw them on a greater level, we'd be a lot more ready to help those countries, and I think we should. The way we're preparing is we're trying to identify people as they come into the door, and then taking those people who might have symptoms and isolating them. And again, it would be a person with a fever from one of those countries, coming from one of those countries, and then they would be tested. The testing is getting better. We can do it within 24 hours. But there are subtleties to that. You might have to have somebody in the hospital for 3 or 4 days. That means you have to have a prepared team in the hospital to take care of those patients. We can do it. We're doing it. People are working very hard to do it. But it's not easy to do, and it requires a lot of resources. We talk about these Tyvek suits. You guys have seen images of the people that wear these hazmat suits. Well, we're trying to get those suits. The supply line for those is shut down. There isn't much out there. So, but again, very manageable. Even with we have other ways to protect ourselves. We want to protect ourselves. The CDC has come out with guidelines. So one, we want to identify people coming in, and we want to protect our healthcare workers. And the way to protect the healthcare workers is to make sure when they go into a patient, they're fully covered. We want to make sure our nurses who do the brunt of the work and the care of these patients, that they're protected, because they're right. If we're not protecting them, why should they go in there? We want to protect ourselves when we go in as physicians, and we can do that. And we're working on doing that. The protocols are getting much more refined and much better. We're learning from Emory, we're learning from Nebraska, we're learning from Dallas. So I think we'll be ready. I see here the bigger discussion, though, which is the broader picture around the world. So I'll stop there.
Thank you, Sandro. Just to follow up on that in terms of preparedness, 3 days ago I was in Tanzania. And I go to Tanzania a lot for my work. I'm there at least 3 times a year. And this was the very first time when I arrived in Tanzania where I had a special form I had to fill out because I now come from an Ebola-infected country. And I just want to point out that it was very interesting to me as the anthropologist watching people fill out their forms, all the Americans on this flight with me, who zipped through this thing, no coughing, no fever, no headaches, no, trying to get out to the immigration line as fast as possible. And when we think about the horrible rhetoric that's been launched against that man in Dallas who is accused of being a terrorist, I just want to point out that, you know, it goes both ways. Let's move on to Adam. Since you study viruses of this nature, and this is an RNA genetic material virus, which doesn't mean a lot to some of us in non-science fields, maybe you could explain a little bit about that to us and talk about drug and vaccine candidates, if you could.
Oh, sure. Thanks for having me. Thanks for organizing it. So I guess 2 questions. So DNA, RNA virus, as you know, DNA, our genes are made of DNA. A lot of viruses have RNA, which is closely related chemically. As a group, RNA viruses tend to have high mutation rates. They mutate to a higher rate than we do, or bacteria, or other DNA viruses. This group has a lot of different viruses, and so you can't really lump them together. There's a tendency to, but this would include things like the common cold is an RNA virus, or most times an RNA virus, polio, flu, hepatitis, measles, mumps. So there's a lot of viruses, and so it's hard to, people want to pin, you know, the mutation as being something unusual in this virus, but it really isn't. And there's a lot of other things that are at play to make it a difficult virus to control. I think that answers your first question a little bit, maybe. And then the other question is drugs and antivirals. Oveta discussed this a little bit. Things you would have heard of are serum. So people who recover from Ebola virus will have antibodies in their blood that, you know, they've used to clear the virus. And so what I understand is being done is you can recover those antibodies from people who are survivors and then give them. And this is a therapy that goes back 100 years in infectious diseases. This is how we used to treat pneumonia before antibiotics. So this is tried and true. So that, I think, is probably the #1 thing that people are thinking about doing and actually doing. ZMapp is an antibody that has been produced, as I understand it, in tobacco plants. That is, as I understand it, the supplies are out. That the company, you know, only had so much they were made, and, you know, scaling up something is really hard. And as I understand it, the people who got ZMapp who recovered, the 2 you know, medical missionaries who were treated at Emory, they were treated with serum before ZMapp, and so it's not clear whether ZMapp was the miracle drug. It might have just, you know, been the serum or the supportive care. And then there are a class of drugs that have been developed for Ebola, specifically, and they are in various degrees of testing. You know, as you can imagine, almost entirely in animals, right? Because it's not easy to do a trial of this sort of thing in people, and so those are being deployed on people, you know, using them. But these are all kind of experimental. No one really knows how well they're going to work because it's completely untested. And then there's a number of drugs that have been developed for other viruses, okay? But then if they test them in a test tube against Ebola virus, it'll work. And so people are like, well, let's try it because we don't have any other data to go with. And so people are trying these things. And these are happening on a case-by-case basis, but then as there's more and more people, you get more and more of a sense of what's the best, what's going to be most effective and what's available. And I think that's something that's evolving. Now.
Okay, great. Thank you very much. So I'm taking questions from the audience and from Twitter right now. First question up is perhaps in your line of duty, but I'm not sure, maybe Oveta, maybe Sandro. I would like to ask about the possibility of the transmission of Ebola evolving as the virus moves through a larger population, becoming, for instance, perhaps airborne. Is this a realistic possibility or a product of speculation?
Okay.
Ask when you answer the question, if you could stand close to the podium,
Okay.
you'll be caught by the camera.
Okay. So Oveta and Sandro pointed to me. Yeah, this is obviously something that's been discussed a lot. I like to say that science can't ever say that something is impossible. It's hard to prove that something's impossible. But what we can say is, based on what we know, this is very, 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 very unlikely. It's the ultimate fear, largely from Hollywood, I think, because the movies have people on planes sneezing, and all of a sudden the whole world is infected. But what we do know is that there are a lot of viruses out there that have high mutation rates, and even with that, it's very unusual for a virus to switch its route of infection. Okay, I'm trying to think of one. It just doesn't happen. And so I was talking to Bob, and he may disagree with me, but HIV hasn't evolved to become a respiratory virus, right? Influenza in people hasn't evolved a different route of transmission. Norovirus, I mean, all these viruses have the way they do it, and it's unusual for a virus to change. And so while that's the fear, and I think everyone wants to keep track of it, I think it's very, very unlikely. And then the other thing to stress is it's not a respiratory disease. It's not a virus that really causes a lot of symptoms in the lungs, and so that's another reason why it's unlikely, I think, to be transmitted that way.
If I could just quickly add, one of the things that people think about is that we've never had Ebola to be in so many people at one time. So is that a fertile field for mutations to occur that will then be more pathogenic or aerosolized or what? And so I agree with my colleague Adam that there's no precedence of a virus changing from one mode of entry to another or mode of transmission. That said, there probably will be mutations, but I think Adam's studies and other studies show that it's very rare that a mutation occurs that actually survives to change the transmission patterns or mode of transmission of a virus. So I don't think that's likely to occur. We concur.
Joe wants to respond. Yes,
Yeah, I agree with everything that's been said with respect to the idea that it's going to change its mode of transmission. But as Oveta said, that mutations do occur, and as these pathogens are transmitted more and more through humans, this virus will change. But there's something called the virulence transmission trade-off, and what generally happens is as a virus becomes more transmissible, it becomes less virulent. And so because a virus, from a virus perspective, it's not very successful virus if it kills the host. So there will be, as long as it is transmitting through humans, there will be mutations, things will be changing. But I think there's no evidence at this point that any property of the virus and of the disease is different than in prior outbreaks, incubation period and the transmissibility. So,
Andrew, please.
So Adam made a great point, which is taking HIV as an example. It's an RNA virus. It's been around for a long time. Its mutation rate is exceedingly high, and it still transmits the same way. Its mutations are concerning when we're looking at drug therapy because it becomes resistant. But in terms of changing the way it's spread, and people that this was said early on in the HIV epidemic, and it is not spread in that way at all. It hasn't changed the way it's spread. It's never become even more transmissible in sexual transmission. The other point to make is Ebola has been around since 1976. This virus is very, very similar, if not almost exactly similar, to the 30 other outbreaks that occurred of Ebola that have occurred in the past. So while we don't understand the virus very well in this continent, there are people that understand it very well and see it as something that's not going to suddenly change and become airborne. So I think we can all feel comfortable that that's not going to be the case. And there's studies coming out now, and I was hoping there's a study from the New England Journal that showed that the transmission dynamics fit much more with what it's been in the past. Nothing has changed in those terms.
Actually, that study shows that in the current outbreak, the virus is going from human to human, and there are minor mutations, but it doesn't change it greatly. It's not coming from animals to humans. These are all human-to-human spreads. A study that is in Science or New England Journal of Medicine.
Okay. Next question, I think directed to Mike and to Gessler and to Renee, are burial customs. Any ability to work with shamans, imams, ministers to develop dispensations for believers so that they can be buried safely and the dead won't lose their afterlife. Let me just say that since I was just now in Tanzania, I've seen the Tanzanian response. They've already prepared themselves for the possibility of Ebola reaching Tanzania. And one of the things that they've done is established local burial committees by neighborhood, and that they're training these people now how to approach that problem should it appear. But let me turn over to other panelists.
Burial, you were saying?
Working with other entities such as religious leaders, shamans, others, to give dispensation is the question, so that believers don't have to go through the normal rites and that there's a fast track to burial and afterlife, I think is whoever, if I'm not, that was yours.
Fast track. You of them had a problem with both Muslims and Orthodox Jews. There's a whole stuff you can do. But if someone has a contagious disease, they can't. They went to the imams and to the Orthodox rabbis, described the disease, and said, which parts of this burial ritual can be dispensed with without changing the belief of the soul? And they made arrangements. Dispensation is essentially
Okay.
Christian word. But most religions, most beliefs have something like it that give permission.
So working with religious authority, if I understand it correctly, working with religious authorities to try to come up with new forms of burial that would still be in keeping with local understandings.
Well, that is one of our greatest problem in Liberia. The Muslims are refusing to consider any change in the burial system. They are bathing the dead, even though the government's saying if a person dies, do not interact with the dead. Let the Ebola team come in, examine the body. If you have died of Ebola, they take the bodies. Muslims are saying no. Traditionally, they have to bathe their people and bury them. So this is one of the major problems we're having. The spread is still going on because we cannot get these people to stop that ritual. It's just...
Why can they do it here and not there? Are the Muslims there afraid of Al-Qaeda or some super Muslim group?
Not really. I don't know. I mean, it's, the government will have to the president had initiated a state of emergency that gives her sole authority to change. Constitutional rights are suspended. So I don't understand why she cannot or they cannot say every dead body should be inspected and taken away.
Okay,
I don't know.
And because that's kind of an unanswerable question, let's move on to what I'm going to do, because time is passing. I'm going to read 3 questions. Please take note if you can answer the question, okay? If you wish to answer the question. First up, how is a moral value being assigned to the virus and the people who have it by both outsiders and insiders? How does this compare with previous viruses such as HIV? Second, what is your take on the claim that Ebola is man-made? Third, what do you think how can the Liberian government help children orphaned by Ebola who've been abandoned by families and communities for fear of being infected? So let's take those 3 right now.
I can do the first 2. Moral value being assigned is very similar to the attitude toward HIV early on, the stigma that goes with getting an infectious disease, that you must have done something to bring it upon yourself. So we see families, and I'm sure Renee and Mike and Gessler can talk to this, where the parents the mother and father may be deceased, and the children are left, which is counter to culture in this region, because families don't know that it's okay to get the children until it's explained how to do that. So there is a stigma, there is a thought about people from the area that should not be there. Viruses essentially infect whoever they can get into. It doesn't matter who you are or what you look like or any of those things, typically age either. It's just how the person gets exposed. And then the second one, the claim that Ebola is man-made, is clearly not true. It is a natural occurring virus. It's reservoirs and fruit bats, and it comes into humans when we come in contact with either animals or people who have come in contact with the virus. Anybody else here want to take a shot at that?
Say something?
Go ahead.
I think there are 2 major drawbacks to people taking in children who have been disadvantaged by the virus. One is fear that they too could contract the virus if they took in children who have been orphaned. 2 is stigmatization. Everybody is afraid of being stigmatized as being associated with somebody who has had the virus. So those are the 2 major drawbacks that I see in terms of taking in children who have been disadvantaged. And the other thing is that the government itself is in the middle of serious national resources. The natural resources have all dwindled because of this attack. So I think we need some kind of robust intervention to assist children that have become orphaned by this virus. Thank you.
Let me follow up with one of the questions I have before me, which says, considering the poverty, limited health infrastructure, density, and the fact that, and I don't know that it's a fact, maybe that needs to be confirmed, that men who survive Ebola can continue to infect sexual partners for up to 2 months. This might be linked to this question about stigma, because even if you've survived it, but if you can still, first of all, is that correct? And secondly, what is the tipping point where we can say this outbreak is now eliminated, or we can't know that because of that?
The answer to the first part of that is yes. So that there are, once the virus is gone from the blood, it can still persist in the semen for, I think, 100 days or so after symptoms start. So it can be there for a long time. And so there are and will be in this country 2 recommendations after that. So the answer to that is it can persist. Not forever, though.
The CDC just changed its regulations. Can you speak to that as well?
I'm sorry?
The CDC recently changed its guidelines?
Guidelines, yeah. The CDC recently changed guidelines for how we prepare and how we put on personal protective equipment in the hospital. That's what changed recently in the CDC. So we're following those guidelines right now.
Okay, thanks. Okay, next question is directed to Michael. What is a disconnect, or where is a disconnect between biomedicine and an authentic community engagement to seeking solutions for containing Ebola? What, in your view, will the international public health community need to do to address the disconnect between biomedical knowledge and local knowledge?
That's a big question. Yeah, and that's really where the crux of the issue is. And I think it has a lot to do with trust. It has to do, look, let's just come down to Liberia. Not so much anymore, but 2 months ago, a lot of people in Liberia were saying that Ebola was a hoax being used by the government to try to squeeze more money out of international donors. right? What does that say? It says that people don't trust their own government. And government in this region, as has already been said, is a hybrid thing. It's not like the Liberian government is 100% in control of governing Liberia. The Liberian government is working alongside the United Nations, all kinds of NGOs, including in this case MSF, Médecins Sans Frontières, and other organizations that are kind of sharing the burden of governance. Right? And so all of these other organizations that are seen as being the partners of, or even the facilitators of, the national governments are also treated sometimes with the same degree of mistrust. Now, this is aside from the fact that not everybody either understands or accepts the germ theory of disease. That's true in this country. I mean, think about all the people who won't vaccinate their kids because they think it causes autism, right? This is very much similar to some of the ideas that are floating around West Africa or other parts of the world. So it's not enough to just imagine that if the outreach brought the proper information to people, it would just kind of seep in and then they would be kind of converted. And then you can work with them. That's not how public health works. All the epidemiology and public health people know that better than I do. So it's, I think, both a question of building trust between government and citizens and this other much more long-term process of which really is going to have to do with people seeing a hospital as a place to go to get cured rather than to die. And that's a 20, 30-year process. So we can't be thinking about that in terms of just Ebola. We have to be thinking about that in terms of a very long-term investment, which, as I say, has to trump a lot of the other things that we have been putting ahead of health and education in line.
Anyone else want to respond? Okay, a more medical question. What is the age distribution of Ebola patients in the affected regions?
It's actually all ages. This virus affects anybody that it comes in contact with. So you have children. The first patient was a 2-year-old. You have older people. You have middle-aged people. A lot of the people that are affected are women because they're typically the caregivers. So if somebody gets sick in the household, they're the ones taking care of them. On the other hand, it's not exclusive to females. Everybody who comes in contact with the virus may be infected. Most of those people get disease. Some 50% are usually fatal.
I'll just add that at the Infectious Disease Society meeting a week and a half ago, there was someone from the WHO who showed the case fatality for Ebola, and it was interesting. I think Sandra said it might have just been published, but there's a big division between under 40 and over 40. Over 40 people do a lot worse than under 40, and so this has been noticed that there's a, I assume that the very young are also at increased risk, but yeah, definitely.
That actually fits with the immune system with diseases that we know about. So it's not that different. It's just because it's Ebola, we've not had experience with it on this large scale. So that's pretty cool to know.
But then that follows well into this next question before me, which is that this is viewed as an unusual outbreak. So should we expect others? If so, where? How can we prepare against transmission on a global scale in the U.S. or further in developing countries? How can we change this?
So there is another outbreak going on in the Congo right now of Ebola, but it's a similar. But they're containing it because it's the usual type of Ebola it's the usual transmission dynamics that they're used to. There's an outbreak of Marburg going on in Uganda. Marburg is another filovirus. Those are usually managed very well, and these have no relation to the outbreak in West Africa in these three countries. So I think the management of Ebola is going to change a lot in some of these countries, and I would ask the panel to comment on that. But I think this experience will change the way we manage, because I think our government, we're talking about trust in government, and I think there are people that don't trust our health care folks, although I think they're doing a great job at the CDC. And our government saying we didn't act fast enough in those countries. And it may be true, but part of the reason is this was seen as kind of a natural way that Ebola goes there. And by the time it really went wild, I think we weren't ready for it. So we're there a bit late.
Since you brought up other hemorrhagic fevers, the question has also been raised about Lassa fever, which in a bad year can kill 5,000. That's the death rate we have right now, roughly, for Ebola.
Yeah.
Yet we don't hear about Lassa on the same order. What is it about Ebola that has made the news?
Well, I mean, flu
around?
kills 45 to 50,000 people a year. So I tell most medical audiences, get your flu shot before I start talking about Ebola, because that's what we should be doing, really. So that, yes, I think that's, we don't, this is a scary disease. There's no denying that for the public. I think to see the way that this is going on and to see people dying is tough. But I would agree, there are diseases that, flu vaccine doesn't work, I heard, but I wouldn't agree with that.
Which is one of the things we want to get out of this panel and this discussion, is that you and I have a responsibility to do what we can. Simply hand washing frequently, especially now in the flu season, is a great way to prevent infection. So those things that we already know how to do, all of us are responsible, whether there's Ebola or not Ebola. We just need to use what we already know. And then to address the question about other outbreaks, I want to emphasize this virus has a reservoir, we think, in fruit bats, where it does not cause them to be sick. But whenever those bats come in contact with animals or humans, and their migratory patterns, they're probably migration of bats from Central Africa to the West Africa area, where they were in caves or in places where people didn't come in contact with them, until somehow patient zero was able to come in contact with something that had come in contact with one. So we will have other outbreaks, because this is a naturally occurring microbe that is in a reservoir in some place that's not going to go away. And so chances are we will have other outbreaks of Ebola. We hope we have learned some lessons from this one, that it will not take hold as this one has done.
Frank?
Thanks, Kelly. I wanted to bring this out to a little bit of a bigger picture as well, because we're talking about a specific disease and the microbiology of it, and this particular issue in history where this virus is exposing these health systems problems. And I just wanted since we're talking about prevention, I wanted to bring up a couple of quotes that Margaret Chan made recently at a speech in Manila about this. And she said, decades of neglect of fundamental health systems and services means a shock like this can bring a fragile country to its knees. And so that's a bigger picture that we're talking about. You cannot build these systems up during a crisis. Instead, they collapse. And so this is what we're experiencing now. And she says, here's one of the few things that WHO is glad to see. When presidents and prime ministers in non-affected countries make statements about Ebola, they rightly attribute the outbreak's unprecedented spread and severity to the failure to put basic health infrastructures in place. And so we're really talking about tremendous inequities in health systems and health infrastructures that have just allowed this particular event to run so rampant. One other quote, I was just at a recent conference in South Africa talking about people-centered healthcare, and this issue came up. Ebola emerged nearly 40 years ago. Why are clinicians still empty-handed with no vaccines and no cure? Because Ebola has been historically, geographically confined to poor African nations. The R&D incentive is virtually non-existent. A profit-driven industry does not invest in products for markets that cannot pay. And so these are deeper problems that are allowing this to happen and the next one to happen and maternal mortality to happen and all these other things. And I think we, as an academy, have, we're talking about beyond Ebola, what can we do? And I think that having that idea of building human capacity and human systems in the countries that we work beside just the particular projects, this is where we move beyond Ebola. And we, as an academic institution, can share our ability to train leaders and build capacity, not just in our country, but in other countries as well.
Thank you, Frank. Devin?
Yes, I'd just like to point out earlier in the discussion that someone made a comment that the flu vaccine doesn't work. I think it's really important that someone said that, because this idea that people are avoiding hospitals or avoiding medicine is seen as something like superstition that's very exclusive to Africa. But you'll see by that quote that it's not. right? Because we just heard that the flu kills 45 to 50,000 people a year. And there is a vaccine available, and some people are not going for it because they feel like it doesn't work. So I think this just goes to show you this is a human condition, these are human responses, and it's not something that's specific to superstitious Africans or have to do with custom burial practices. We got a phone call from someone doing an article, and they wanted to interview someone about, traditional burial practices of West Africa. And as an earlier panelist said, the traditional practices, you love someone, they die, you want to show your love and affection for them and take care of them if they're sick, or also care for them after they're gone, and then you bury them. I mean, that's not traditional to Africa. That's a human condition. That's what we all do. If someone is sick, if someone you love right now is sick, you don't want to send them away somewhere that you may not see them again. I mean, it may not be logical, it may not fit the science, but it's our human instinct to care for and want to be close to those we love. So I just wanted to kind of jump on that opportunity when someone said it. And people are welcome to have that opinion, just as some people are welcome to not want to take their loved one to an Ebola crisis center because maybe they have malaria and maybe they don't know that. So I just wanted to, really wanted to point that out because it's very upsetting, I think, to all of us to hear, things sort of set aside and restricted to a certain area that a certain group of people behave a certain way. And really, we are those people. We are the same people being affected by Ebola, just as Renee's sharing, how your life is affected if all of a sudden you're told don't go anywhere, don't do anything. Nancy Snyderman couldn't do it. So I just like to
Thank you, Devin. Devin is the program manager for the African Studies Center. All right, we have essentially no minutes left, but I will I'll read these questions quickly so that they can be heard. And if in your final, you're going to each be given a minute to a minute and a half to say whatever you want to say as final take-home points. So running quickly through these, can some of you speak more to the international response and its coordination or lack thereof? It appears to be a repeat of colonial-era relationships with little multilateralism. And why is there this military response? We may be committing more resources, but is this really going to be an effective strategy for bringing the epidemic under control? That's the first. Second, how might ethnic differences impede hospital building and other infrastructure creation? Third, what will be the likely outcomes for Liberia as a country, for the region, and for their families? Fourth, is self-isolation the answer to contain the illness? You're giving me two more. Okay. Are there any host vector models that could be used to study Ebola, like guinea pigs for TB or mice for other diseases? What is it about infectious diseases like Ebola that have led to a paucity of vaccine research despite being around for decades? And finally, if 50 suicidal terrorists deliberately infect themselves with Ebola and then travel to the U.S., etc., before their symptoms have developed, could this overwhelm the healthcare system? Is this a possible scenario? So take your favorite. Let's start. Frank?
Well, the only thing I would say is in terms of the military can produce health systems very quickly. They can bring hospitals, they can bring people, they have equipment, and I think that's what you're seeing. It's like you're creating this mini health system that doesn't exist. Places for isolation and for supportive treatment, and those are the type of health systems that need to be built in the countries. So,
thank you. Adam?
Let's see, vaccines. Why don't we have enough vaccines? I think there's a lot of reasons. It's some viruses are harder than others for vaccines, and then the other is there's a market issue. It's a failure of markets because you have a disease that in most years aren't that many people, and there's not a lot of customers for vaccine. And then there was another virus one, but I don't remember.
Vector models?
Oh, yeah. It infects fruit bats, so people are studying in fruit bats. The CDC actually has, through much difficulty, a fruit bat colony. And imagine that in Atlanta. And there are mouse models, and then there's primate models that people use.
Thank you.
I guess I get the bioterrorism question. Well, and first of all, I just want to say I really enjoy this type of interaction because we really get so focused on many things at the hospital level, but this is a great discussion to bring it back to 10,000 feet and what we should be thinking about as a population, I think. In terms of the bioterrorism issue, I don't think it's a very efficient way to spread bioterrorism. When I give lectures on bioterrorism, we mostly talk about aerosolization. It's unlikely that people would be able to aerosolize Ebola in the way that it would cause massive problems. We could handle 50 people with Ebola, and even the specter of a few more. So I don't think people should get too overly concerned about that. I think there's enough anxiety over people just coming in on airplanes.
Well, I think it's a lesson well learned by the government and the Liberian population. I think next time people will not just downgrade a news that can bring danger. And I also think that the three countries, Liberia, Guinea, and Sierra Leone, will see the wisdom of integrating the health systems more and more in light of this outbreak. Thank you.
You want to start? Maybe the self-isolation one. Could you hit that one? Self-isolation as an option. Self-isolation as a way to contain the illness. Is that a possibility?
Well, I don't think it's. Certainly, it's an option. It doesn't seem like a structurally sound way to deal with this outbreak, or most outbreaks. I think that thing that I wanted to really emphasize at the end here is that emergence of new diseases is really a constant in this world. That emergences have been occurring for 10,000 years, ever since we've started agriculture, and it will continue to occur. So we're going to be seeing emergence of outbreaks. HIV is actually a good example of a region's emergence that has caused huge public health burden worldwide, much more than all the Ebola outbreaks combined. I study diarrheal disease, and it's considered one of the mundane diseases in the world today, forgotten diseases, but it still is a major killer in the world today. As Sandro mentioned, influenza in this country alone kills tens of thousands of people every year, which is again more than the total number that of people have died in Ebola since Ebola's emerged in the early mid-70s. So even though Ebola is very devastating, it needs to also be in context of larger public health issues in the world today. But I just want to end with but to ensure that Ebola stays a minor player in the public health landscape, we really have to better understand how we are changing the environment in different ways and how those changes in the environment results in these emergence. And I think this outbreak is a really wake-up call about how these environmental changes causing emergence, coupled with poor health infrastructure, impoverished communities, can have devastating results.
Okay, like what Gessler has said, my hope is for my government, Liberia, to invest more in the public health. About 90% of the hospitals and clinics in Liberia are privatized. Government hospitals are about 5%, I don't know, less than that maybe. Over the past 40 years, I think they only built about 3 or 4 public hospitals. So I hope this is a wake-up call, and I'm hoping that they can invest and empower the health workers. Thank you.
Thanks. I just want to say, right now we're at the height of the harvest for rice in West Africa. All 3 of these countries, people are overwhelmingly rice farmers, and that's what people eat 2, sometimes 3 times a day. People are not going out to harvest their rice because people are sick. People don't want to gather into the large groups that actually tend to do the agricultural labor during the bottleneck periods. And just as schools are shut down, just as health centers that have shut down are allowing women with difficult childbirths to die, and people with malaria and all kinds of other diarrheal diseases to die in much greater numbers than Ebola. It's like a series of concentric circles that go out from Ebola in a very already fragile situation and have all of these other sort of ramifications. And so if people don't have enough to eat, what are they going to be doing? They're going to be looking for wage labor in cities. First, they're going to go from the countryside to the cities, to Monrovia and Freetown and Conakry. Then they're going to be going to the cities like Abidjan or Dakar, where there may be even more possibility of work. What are people going to be doing if they have no money to buy beef or smoked fish to put in their soup sauce? They're going to be hunting bushmeat, right? Where supposedly the Ebola came from in the first place. So there's a whole series of knock-on effects that come out of an epidemic like this in a fragile situation that actually can end up killing and harming a lot more people than the disease itself. And so we shouldn't lose sight of that. Just as we shouldn't have put all of our eggs in the security basket and forgotten about health, we shouldn't now put all of our eggs in the health basket and forget about agriculture and education and the rest.
Okay, thank you. I just want to remind you that the biology of Ebola virus means that it's going to be here in one form or another for the future, and that what we have at the moment is education, prevention, isolation, and containment to control it. Lastly, fear and the lack of responsibility, the misconceptions that are out there have really no place in being able to control it. So you need to be educated, we need to be educated, and we need to pass that information on. And lastly, I know there are a number of students in the audience as well as some of the faculty, that one of the things that we can do is not only educate people in one area as in biology or as in epi or as in anthropology, but realize the value of the interdisciplinary work and education that a place like the University of Michigan can do, such that when these things do occur, and they will occur, we have people who are equipped both intellectually and culturally and morally to do what's necessary to help them. And I think the African Studies Center and the International Institute, Global Reach, and many other places here at Michigan have a huge role to play in that. So thank you.
Thank you. So I'll just end by saying that on August 18th, the president of the World Bank, Jim Yong Kim, together with the chairperson of the African Union, Nkosazana Dlamini-Zuma, issued a joint statement where they said the way to stop Ebola and prevent future outbreaks, it requires 4 steps. Number 1, support healthcare workers on the front line. Number 2, provide Liberia, Sierra Leone, and Guinea with more of everything they need to combat this, from doctors to mobile laboratories, rapid testing equipment, food, and other forms of support. As we've heard in the news, Liberia has 1 doctor for every 70,000 people. Compare that to the U.S., where you have 1 doctor for every 400 people. Number 3, we need better communication, both within and across international boundaries. And number 4, we need stronger health systems in these countries so they can respond more effectively. The inequity in the global access to healthcare should not be tolerated. Thinking beyond this Ebola outbreak means thinking beyond the commonplace acceptance of the world as it is. It's no longer acceptable. I want to end by thanking all the staff who supported this event. First off with Pauline Jones-Luong, the director of the International Institute, for having these II roundtable discussions. Thank Devin Keene, Margot Lakin, Sandy Schultz, Pat Lord for supporting the event today, Jim, our IT guy, and all of you for attending. Thank you to all the discussants and the panelists. The conversation continues over coffee and drinks outside. Thank you.